So welcome you all again for the this session on OSCEs in neonatology, which we believe will be useful for PG students in pediatrics as well as fellows and DM students in neonatology. So these are few commonly asked questions, which include a combination of few investigations, some radiology images, some clinical pictures, and some commonly asked questions related to these images. So let's begin with this straight away. Question 1. This is a term baby, 2,800 grams boy, who was delivered by a normal vaginal delivery. The baby developed severe respiratory distress and cyanosis at birth. The baby needed neonatal resuscitation in the form of bag and mask ventilation, persistent cyanosis, as well as bradycardia. The baby was intubated and referred to a tertiary care center at 2 hours of life. On arrival, the baby had a heart rate of 50 per minute, which means it was bradycardia. The baby had cyanosis with chest asymmetry on bagging with faintly heard breath sounds on the left side. So this was the X-ray that was done outside. This was before the baby had the deterioration. So as you can appreciate in this X-ray, we can find that there is mediastinal shift towards the right hemithorax. You can see a very small portion of the right lung that can be seen pushed towards the corner, and there is herniation of intestinal loops into the left hemithorax. So this is a case of congenital diaphragmatic hernia. This baby has presented to us postnatally with cyanosis, respiratory failure, as well as bradycardia. So we know that up to 50% of the times, CDH can be diagnosed antenatally, and sometimes we may not have this benefit of antenatal diagnosis. So this is the first chest X-ray. So the diagnosis is, of course, left-sided congenital diaphragmatic hernia. Now, what could have caused the sudden deterioration in this baby, and how will we manage this? So sudden deterioration in congenital diaphragmatic hernia, the potential reasons could include pneumothorax. It might be because of PPHN. It could be because of secondary factors like infection or a ventilator-associated pneumonia, because these babies might require prolonged respiratory support. The other reasons could be reasons which are usually seen in mostly in normal ventilated babies, like tube displacement, tube obstruction, need for suctioning, secretions, etc. Sometimes we may have deterioration because of abdomen compartment syndrome post-surgery, when the diaphragm is pushed downwards, pushed inferiorly during the repair. So these are some of the causes. Now, in this case, the question scenario said that there was also distantly heard heart sounds in the left side. So this is characteristic of pneumothorax, and hence one would like to do transillumination immediately, rule out a pneumothorax. And if present, one would immediately go for needle thoracentesis with ICD placement. Now, another commonly asked question here is, what are the poor prognostic factors in CDH? And we have to mention, the question says any two of the poor prognostic factors. So there are multiple poor prognostic factors, starting from early diagnosis. So the earlier CDH is diagnosed, the worse will be pulmonary hyperplasia, and hence poorer will be the outcome. And pulmonary hyperplasia can be also diagnosed directly with multiple markers like LHR, which is lung head ratio, or lung thoracic ratio, which is LTR. Other poor prognostic markers include the presence of liver in the hernia, a right-sided diaphragmatic hernia where liver can be a component, because liver tends to be a solid organ and the compression on the lung can be more severe. Presence of associated polyhydramnios, which happens when the baby is unable to swallow the amniotic fluid. The presence of concurrent associated cardiac anomalies, particularly left ventricular hypoplasia, can also make the prognosis grave. So we have discussed most of this. You may be asked questions on how to assess the severity of pulmonary hyperplasia. So there are various indices, LHR, LTR, lung head ratio, and lung thoracic ratio. You may also be asked how these parameters are measured. Like, for example, how do you measure the lung head ratio? So it's obviously a ratio of the lung volume divided by the head circumference. Now, how we measure the lung volume is often asked. Usually, it is measured by taking the product of two perpendiculars from the contralateral hemithorax, drawn at the level of the cardiac atria. The last question in this particular scenario was, what is the best ventilatory strategy to manage this baby? So the babies with diaphragmatic hernia tend to have pulmonary hypoplasia and tend to have high risk for developing air leak, and hence they need to be ventilated very carefully with the least possible peak inflation pressure and PEEP in order to minimize lung injury, at the same time in order to maintain some gas exchange. So we try to accept a pH of as low as 7.25, meaning provided the pH is more than 7.2 or 7.25, we should accept PCO2 levels of up to 60 to 65 millimeters of mercury in order to practice permissive hypercapnia. Join Kadu. I want to do the presentation from there. First, I was trained. Accept saturations of more than 85%, and early rescue high frequency oscillation can be tried whenever there is high risk of air leak. Unlike the earlier norm when surgery was expedited, now it is believed that delayed surgical repair must be done after the pulmonary arterial hypertension stabilizes. So one of the important risk factors for postnatal morbidity and mortality is PAH. So it's always important to remember that it is preferable to do delayed surgical closure in the cases of CDH after the PAH stabilizes, where outcomes would be better. So we'll move on now to the second question. The question is, you can see that on the left side, there is a picture of a baby with features phenotypic evidence of trisomy 21 or Down syndrome. So what is the most common malformation seen in this baby? That is the first part. What are the possible reasons for recurrent vomiting, delayed passage of stools in such neonates, and name 3 characteristic facial phenotypic features. So Down syndrome or trisomy 21 is a quite a important area which can kind of be often asked in exams. So there are multiple anomalies that can be associated with Down syndrome or trisomy 21. You are aware of associated hematological anomalies, cardiovascular anomalies. They carry a 30 to 50% association with cardiovascular anomalies, GI gastrointestinal abnormalities, particularly conditions like duodenal atresia, ileal atresia, jejunal atresia, tracheoesophageal fistula, Hirschsprung disease. There can be associated renal abnormalities. There can be facial dysmorphism of various types. So these are common exam-rich areas, question-rich areas. So among this, one of the commonest type of anomalies is cardiovascular abnormalities. The very specific cardiovascular abnormality associated with Down syndrome is endocardial cushion defects, which can be seen in up to 50% of these children. So if you see a systolic murmur in a baby with obvious phenotypic evidence of Down syndrome, very likely we are dealing with a endocardial cushion defect, also referred to as atrioventricular septal defects. So in a baby with Down syndrome, if you see recurrent vomiting and open that PPT. PPT system open చేయండి ఈ సిస్టమ్ PPT డౌన్లోడ్స్ చూడండి. So if you have a baby with Down syndrome having recurrent vomiting and delayed passage of meconium, we could be dealing with a number of conditions. One of the common conditions is Hirschsprung disease, which has an important association with Down syndrome. Also, we may be dealing with intestinal atresia or hypothyroidism. Now, hypothyroidism is also something that is commonly associated with Down syndrome. So every baby with Down syndrome should have screening, TSH and free T4 levels, which must be done after 48 hours. The common facial abnormalities that are seen with Down syndrome include epicanthic folds, mongoloid slant of the eyes, flattening of the occiput, and small frontal bone, small nasal bone, as well as hypertelorism, which is because of the widening of the desktop, widening of the area between the two eyes, opening of the mouth, and protuberant tongue, in association with small posteriorly rotated ears. Now, how can Down syndrome be diagnosed antenatally? One of the important aspects is triple screening. So in triple screening, we look at 3 maternal serum parameters: alpha fetoprotein, unconjugated estriol, as well as human chorionic gonadotropin. The typical abnormalities seen in triple screening would include low levels of alpha fetoprotein, low unconjugated estriol, as well as high levels of human chorionic gonadotropin (HCG) levels. So this is the characteristic pattern in triple screening. Another important associated screen that is often done these days is the quadruple screen, in which the fourth component is inhibin A. So remember that Two of the three components in triple screening are decreased, the AFP and unconjugated estriol, whereas HCG is high. We can remember H or similar mnemonic. HCG is elevated and the other two parameters in triple screen are usually reduced. Note that alpha fetoprotein, which is the parameter that is also used in screening for neural tube defects and open abdomen wall defects like gastroschisis and omphaloceal, can be used as a marker of some other anomalies, and AFP is elevated in these conditions like neural tube defects or open abdomen wall defects, whereas it is decreased in trisomy 21. So this is a X-ray of a baby with Down syndrome. You can see that there is a classical double bubble sign. So if you see double bubble sign in a baby with Down syndrome, then we are usually dealing with duodenal atresia. There are some other reasons for double bubble sign, which is indicative of obstruction at the proximal duodenum. So these other causes include an anomalous SMA, which is causing the obstruction, or annular pancreas. But particularly in a baby with Down syndrome, double bubble sign can be a sign of duodenal atresia. There are other signs in X-ray such as triple bubble sign, which can be seen with jejunal atresia. And if you see multiple bubbles, it is considered to be a sign of ileal atresia. Duodenal atresia in isolation carries excellent prognosis. 95% of the newborns with isolated duodenal atresia will have otherwise normal outcome. So one important anomaly or important chromosomal anomaly that needs to be ruled out when you see duodenal atresia otherwise is again Down syndrome. So we'll move on now to question 3. I was hoping I'll do this presentation from my iPad and use the pen for some of these parameters. But we'll try to do it with this in the regular format only. So what does this picture depict and how do you calculate what we are trying to calculate? So this is the picture. This is obviously echocardiographic image. So you can see that this is a Doppler assessment of some velocity. And from the image, we can understand that the assessor is trying to measure the velocity of blood flow across the tricuspid valve. So what we're trying to assess is flow which is against the probe or away from the probe, and hence this seems to be the flow of tricuspid regurgitation because the probe is placed towards the ventricle, atria is away from the ventricle. So this flow which is away from the probe must be happening from ventricle to atria. So this is tricuspid regurgitation velocity that we are trying to measure. So now how do we calculate it? We all know that there is something called Bernoulli's equation, which depicts that flow in a chamber is equal to 4V square plus the flow in the chamber from the lower pressure chamber. So here, since tricuspid regurgitation jet is flowing across the tricuspid valve from the ventricle to the atrium, the ventricle is obviously at the higher pressure. Hence, right ventricular systolic pressure is represented by 4V square plus the pressure in the low pressure chamber, which is the right atrium. The right atrial pressure, most conventionally, is taken to be equivalent to the central venous pressure or CVP. So we'll take a example. So supposing this V is, let's say, 2 meters per second. V square 2 into 2 is going to be 4. 4 into 4 is 16. So 4V square is 16 plus right atrial systolic pressure, let's say it is 5 if CVP is equal to 5. So 16 plus 5 will be equal to 21. So 21 is the right ventricular systolic pressure. Now, based on the concurrent the systemic pressure, usually the right ventricular systolic pressure will usually correspond to the pulmonary artery systolic pressure. So we can kind of find out, decipher whether this baby has mild or moderate or severe pulmonary hypertension. Generally, when we are treating PPHN, we try to target that the systemic pressures, mean arterial pressure on the systemic side is maintained at least equal to or if not greater than the pulmonary artery systolic pressure. So this is a baby who has conventional ventilation with the following parameters. Let's say PIP is 25, PEEP of 6, MAP is 14, and the rate is 40 breaths per minute, FiO2 of 90%. So preductal saturations are 90%. Sorry, preductal oxygen saturation is 75%, and postductal blood gas is given here, in which PO2 is only 30 millimeters of mercury. So question here is to calculate oxygenation index. So how do you calculate oxygen index? So this is the formula for calculating OI. OI is one of the important measures of oxygenation in a baby. So this is given as a product of mean airway pressure into fractional inspired oxygen concentration in the numerator, and it is divided by the postductal PaO2 in the denominator. In this particular example, we saw that the map that the baby is being given from the ventilator is actually 14. They have given upfront that map is 14 centimeters. FiO2 is 90%. So FiO2 is taken as 90, which is otherwise you can take as 0.9 into 100. So 14 into 90 in the numerator divided by the PaO2 from the postductal ABG, which is 30. So remember a few things. MAP, we always take the two parameters that we are giving on ventilator to improve oxygenation in the numerator, and what we assess from the baby to study oxygenation in the denominator, which is postductal PaO2. We, as a convention, take the postductal PaO2 wherever you have both preductal and postductal. Remember that we should take postductal because it is more representative of the severity of PPHN. So in this particular example, it is 14 into 90 divided by 30, which is equal to 42. Now, how do we interpret OI? So OI of more than 20 or some textbooks say 25 is taken as an indication to start inhaled nitric oxide. And OI, which is crossing 40, especially when we are on high frequency ventilation, and if multiple blood gases taken more than 1 hour apart are showing OI more than 40 on maximum settings on high frequency, then this is taken as an indication for ECMO or extracorporeal membrane oxygenation. Okay, the next question is, what are the two maternal antenatal medications that can lead to this condition? So common antenatal drugs that can lead to PPHN are non-steroid anti-inflammatory drugs like aspirin and selective serotonin reuptake inhibitors. Both these drugs can cause constriction of the ductus and PPHN in the fetus. The endothelin antagonist that is used to treat the condition. So endothelin antagonist used to treat PPHN is bosentan. Now there are multiple therapies used for treating PPHN. Inhalational gas, we discussed about inhaled nitric oxide. Among pharmacological agents, commonly used drugs are sildenafil, which is phosphodiesterase inhibitor. We can use milrinone, which is also used as an inotrope, which is a phosphodiesterase 3 inhibitor. It is also called to as inodilator, and it has excellent lucitropic action or promotes myocardial relaxation in addition to causing pulmonary vasodilatation as well as increased inotropic. There are some relatively newer drugs that are used to treat PPHN, which include, especially in the neonatal literature, like magnesium sulfate, prostacyclin, which is PGI2, and bosentan is coming up these days. It is an endothelin receptor antagonist. Now, what is a drug that is indicated when the oxygenation index exceeds 20? We already discussed inhaled nitric oxide. Some books would take this cutoff as 25 as well. But usually, the 20-20-20 rule is good to remember. We start inhaled nitric oxide at a OI more than 20 with a dose of 20 parts per million. The dose of nitric oxide is measured as ppm or parts per million. So we start with 20 ppm when OI, postductal OI crosses 20, and we ideally repeat the PaO2 after 20 minutes. So we must see the response in 20 minutes of the therapy is what the standard teaching says. Likewise, we use the 60-60-60 rule while we are weaning nitric oxide, which is also important for all PGs and for neonatal intensivists to remember. We start weaning nitric oxide when we reach FiO2 requirement less than 60% with PaO2 that is more than 60 millimeters of mercury. And at least after 60 minutes of therapy is what, again, the 60-60-60 rule says. So we have discussed about PPHN in the earlier scenario. We move on to the next question. What is this chart? Identify the chart. What is the clinical application? What would you advise for a baby between 35 to 37 weeks in the high intermediate risk zone? Mention two risk factors for severe hyperbilirubinemia, and when would you prefer to do a TSB instead of TCB? So neonatal jaundice again is a very MCQ and OSCE rich area. This chart is called as Bhutanese nomogram. Bhutanese nomogram is a chart that is not used for deciding when to give treatment for phototherapy. It's not like a chart like the AAP chart to decide the level of bilirubin at which we treat with phototherapy or exchange. Rather, this is a nomogram that is used for risk prediction for severe hyperbilirubinemia. So, based on the postnatal age that is represented in the x-axis, and the bilirubin levels, where you can either use serum bilirubin or transcutaneous bilirubin represented in the y-axis. We can categorize the baby into 4 different zones: low risk zone, the low intermediate risk zone, high intermediate risk zone, and high risk zone. These zones are useful for predicting the subsequent risk of development of severe hyperbilirubinemia. So low risk zone represents 0 to the 40th centile. Low intermediate risk zone represents 40th to 75th centile. High intermediate risk zone represents 75th to 95th centile, whereas the high risk zone represents bilirubin values above the 95th centile for that postnatal age. So this is applicable when we are discharging a baby who apparently doesn't have significant jaundice on clinical assessment. You would have performed a transcutaneous bilirubin or a serum bilirubin based on the postnatal age and based on the other investigations that are needed, or based on your unit policy. Now, once you have got a certain bilirubin value, which is well below the phototherapy threshold for that baby, when do you advise this baby to return back for a follow-up based on the risk of further development of hyperbilirubinemia? So this question is what this chart tries to answer for you. So if you find the baby to be in the low risk zone, there is almost 0% chance of the baby developing severe or serious hyperbilirubinemia. In low intermediate risk zone, this risk is around 2%. In the next high intermediate risk zone, the risk will be around 13%. And in the high risk zone, the risk is almost 90%. So based on this risk, we can predict the risk of subsequent severe hyperbilirubinemia, which is defined as bilirubin levels more than 95th centile within the first 0 to 144 hours. The high intermediate risk zone, wherein this current index baby is falling in, will mandate a repeat bilirubin within 24 hours, ideally between 4 to 24 hours. Whereas if the baby falls in the high risk zone straight away, then it is better not to discharge the baby. It is better to observe the baby in the hospital because there is high risk of subsequent hyperbilirubinemia requiring phototherapy. Now, there are multiple risk factors for severe hyperbilirubinemia per se, and these are some of these risk factors. So, lower the gestational age, especially gestational age is less than 35 weeks, developing jaundice in the first 24 hours, pre-discharge transcutaneous bilirubin or total serum bilirubin, which is close to the phototherapy threshold, or you may say TCB or TSB levels, which are in the high risk zone in the Bhutanese nomogram, presence of hemolysis from any cause, which is well established or which may be suspected based on a rapid rise of serum bilirubin. Rapid rise is defined as more than 0.3 milligram per deciliter per hour in the first 24 hours or more than 0.2 milligram per deciliter per hour thereafter. Requiring phototherapy before discharge, history of sibling requiring phototherapy or exchange transfusion, and parent or sibling requiring phototherapy, family history or genetic ancestry suggestive of inherited blood disorders, including G6PD deficiency and exclusive breastfeeding with suboptimal intake. Scalp hematoma, significant bruising, presence of Down syndrome, as well as macrosomic infant. So these are all some risk factors to develop significant hyperbilirubinemia. I've shared screen this. So presence of multiple risk factors also must prompt us to have a high index of suspicion for following up the baby with for serious or significant hyperbilirubinemia. Remember, these risk factors are different from the risk factors for bind or bilirubin encephalopathy, and the AAP nomogram gives us some important risk factors for developing bilirubin encephalopathy. These include factors such as asphyxia, significant lethargy, significantly decreased feeding, presence of hypoalbuminemia, there is serum albumin levels which are low, the presence of concurrent G6PD deficiency, ABO or RH incompatibility. All these are considered to be risk factors for developing bind. Some of them may overlap with the risk factors for severe hyperbilirubinemia, especially history of hemolysis known or suspected, but not all of them. Now, the conditions in which TCB more than where we would not trust or rely on transcutaneous bilirubin levels are when TCB levels go up to more than 50 or they are within 3 milligram per deciliter of the phototherapy threshold for that postnatal age, or when TCB is performed beyond 14 days of postnatal age. In all the situations, it's better to go for TSB rather than the TCB. We'll continue with the presentation again. Question 5. So what is this graphic? And can you mention the abnormality that is represented here? What are the three advantages of volume guarantee ventilation? Components of VAP bundle. What sensor is mandatory in order to measure the tidal volume? And a baby had sudden deterioration on ventilator. Would you like to you want to rule out DOPE, and what does it stand for? These are all the questions in this particular OSCE. So this particular pulmonary graphic is called as a flow volume loop. It has flow represented on the y-axis and volume on the x-axis. And flow volume loop is one of the commonly used pulmonary graphics to find out various ventilator-related misadventures like air leak or air trapping. When you have a portion in the flow volume loop where the graphic is not coming back to the point where it started, and if this particular gap is seen along the volume axis, this represents air leak. Sometimes you may have a similar problem seen on the flow axis where the expiratory loop doesn't come back to the starting point, where you make a diagnosis of air trapping. But here you can see that on the volume line or on the x-axis, the expiratory loop doesn't come back or doesn't reach the point where the inspiratory loop started. So this is representative of some volume that is lost or leaked during expiration. So this is representative of air leak. Air leak very often can be peritubal leak, but sometimes you may also see air leak due to other lung issues, like if there is a fistula, a tracheoesophageal fistula, or if there is a bronchopleural fistula, or there is a large pneumothorax. Again, we may be able to see air leak. Okay. What are the advantages of volume guarantee ventilation? Volume guarantee is a type of volume targeted ventilation where you have control over the tidal volume that is being delivered during the ventilator breaths. So what is the advantage of this strategy? Evidence and studies have shown that use of volume targeted modes of ventilation results in lesser risk of pulmonary air leaks, pneumothorax, risk of barotrauma, volutrauma, developing cerebral complications like intraventricular hemorrhage, periventricular leukomalacia, and inadvertent hypocarbia during ventilation, as well as overall reduced risk in developing bronchopulmonary dysplasia and combined outcome of BPD and death. So these are some important clinical advantages, and hence volume guarantee mode of ventilation has more and more become popular in these days because of all these advantages. Three components of VAP bundle. While giving ventilation to the baby, we all must be careful to prevent infection. And VAP bundle or ventilator associated pneumonia prevention bundle has multiple components. It starts from hand hygiene. It starts from minimizing the need for invasive ventilation or early extubation wherever the baby is already ventilated, early extubation to non-invasive modes, to CPAP, extubation to as soon as the primary pathology is better, the use of horizontally fixed endotracheal tubes, and optimal care during suctioning, 2 persons to be present during suctioning, and humidification to be optimized during ventilation, and delivering gases at 36.5 to 37 degrees Celsius with 100% relative humidity. So there are multiple checklist points for prevention of VAP, and you can always mention as many as the examiner wants. Some important other precautions also include the avoidance of certain drugs, particularly H2 blockers like ranitidine, which can alkalinize the gastric pH and can increase the risk of colonization of the baby's lungs. And encouraging the use of enteral feeding as early as possible, as soon as the baby is clinically stable, and using breast milk as much as possible. Now, what device must be present for doing volume guarantee mode of ventilation? A flow sensor must be present in order to measure the flow during inspiration, during expiration. And when we measure flow, we automatically end up measuring the tidal volume. Some important complications during ventilation include displacement, obstruction, pneumothorax, equipment failure, which are summarized using the acronym DOPE. D for displacement, O for obstruction, P for pneumothorax, and E for equipment failure. Next question. A 12-day-old term male baby with birth weight of 3,000 grams was treated for septic shock with IV antibiotics and eye drops. Now the baby presents with persistent thrombocytopenia. The baby had an umbilical venous catheter for the initial 5 days, which was removed, and a peripherally inserted central catheter was inserted in the left lower limb on day 6, through which the baby was receiving inotropes. Now the baby is off inotropes and is receiving IV antibiotics for culture positive sepsis. Limb Doppler showed thrombosis along the left femoral vein. So this baby has femoral venous thrombosis and has persistent thrombocytopenia. So the question is, what are all the causes for late onset thrombocytopenia? What is the most common cause for neonatal thrombosis? What is the treatment option for neonatal thrombosis? And what do you mean by scrub the hub to prevent CLABSI? Thrombocytopenia, again, is one of the commonest hematological abnormalities in neonatal ICUs. It can be either early onset or late onset thrombocytopenia. Early onset thrombocytopenia can be due to some conditions such as asphyxia, torch infections, that is in utero infections, early onset neonatal sepsis, newborns, otherwise stable newborns who are born to mothers with uteroplacental insufficiency, who may also have thrombocytopenia, and neonatal alloimmune thrombocytopenia, which is a unique condition, alloantibodies mediated thrombocytopenia, wherein the mother's platelet count can be normal, but the baby's platelet count can be low. If both mother and baby have immune thrombocytopenia, this is called as isoimmune thrombocytopenia. But alloimmune thrombocytopenia is generally associated with much more serious thrombocytopenia and also associated intracranial bleeds. Question here is about late onset thrombocytopenia, which is seen after 72 hours of postnatal age. This is usually due to sepsis, bacterial or fungal sepsis, necrotizing enterocolitis, disseminated intravascular coagulation, secondary to sepsis or secondary to an immune inflammatory reaction. Viral infections, particularly infections such as dengue, chikungunya, are known to cause thrombocytopenia. Herpes is known to cause thrombocytopenia, and likewise congenital or acquired cytomegalovirus infections. So these are some viral infections that can cause thrombocytopenia. And what we saw in this scenario, which was a indwelling thrombosis. There can also be drug-induced thrombocytopenia, which can be seen with some antibiotics. Inborn errors of metabolism, particularly organic acidemias like propionic acidemia, isovaleric acidemia, methylmalonic acidemia, and as a part of bone marrow failure or Fanconi's anemia. The commonest cause for neonatal thrombosis in NICUs is a presence of indwelling vascular catheter. And it is said that neonatal thrombosis is much more common than what we believe and what we diagnose. So when you're dealing with neonatal thrombosis, it is important to evaluate for the cause, especially when it is occurring in the absence of indwelling vascular lines. It is important to rule out prothrombotic states. And treatment will be in the form of heparinization. These days, we are using low molecular weight heparin very commonly. But very often, unfractionated heparin may be used in the initial phase of anticoagulation, and it may be overlapped and continued with low molecular weight heparin. Thrombolysis with TPA may be required in selective cases of limb-threatening or life-threatening thrombosis. So where the thrombosis threatens either life or the salvageability of a limb, then we may have to consider thrombolysis, especially when we are seeing this early, remembering that there is a high risk of bleeding with TPA. The last question, scrub the hub, refer to a strategy to reduce the risk of CLABSI, which is central line associated bloodstream infection. So this involves scrubbing the hub of central lines for at least 15 seconds using a alcohol swab or a chlorhexidine soaked gauze in order to prevent CLABSI before connecting any injection to a central line. We'll move on now to question 7. So here, this is about breastfeeding. Now, there are two positions that are being shown in this particular OSCE. So one is to name the position that is being used, mention two indications for this position, and name the signs of good latch, any two signs of good latch. The question also is about functions of human milk oligosaccharides or HMOs, and mention two absolute contraindications for breastfeeding or expressed breast milk. So there are a number of named positions in breastfeeding. This particular position is something called dancer's hold position. And this is indicated in prematurity, hypotonia, in babies with hypotonia like Down syndrome. So this is a condition where the mother uses the fingers of one hand, wherein thumb and the index finger are used for holding the baby's head, and the other fingers are used for supporting the breast. So this position can be particularly useful when the baby is hypotonic, as seen in prematurity, and in Down syndrome. The signs of good latch include the baby's chin touching the mother's breast, baby's mouth wide open around the breast and not just the nipple, baby's lips being averted, most of the areola and the nipple being covered by the mouth. So you may be given pictures of good and inadequate latch. Remember that for identifying good attachment, the baby's chin must be touching the breast, baby's mouth should be wide open, and it should be covering the whole areola, lips averted, and most of the areola must be covered by the baby's mouth. We also should remember the signs of good positioning, which include the baby's whole body must be well supported. The head and the body are aligned in a single line. The baby's body must be turned towards the mother, and baby's abdomen should be touching the mother's abdomen. These are the 4 signs of good positioning. Now, when it comes to breast milk components, there is a lot of buzz now about HMOs, which are human milk oligosaccharides. HMOs are non-digestible carbohydrates that are passed on from the breast milk to the baby, and they have various immune properties, including antibacterial, antiviral, anti-inflammatory effects. They provide short-chain fatty acids, particularly short-chain butyrate, and immune modulators, prebiotics, which modulate the intestinal epithelial response. Now, these prebiotics, human milk oligosaccharides, are found to modulate the pattern of the gut microbiome in a favorable fashion, wherein good bacteria like lactobacilli and bifidobacterium may predominate in the baby's gastrointestinal tract in predominance, or as opposed to some potentially pathogenic bugs like the Firmicutes class of bugs, gram-negative bacilli, or Enterobacteriaceae or anaerobes. So there is more and more discussion on HMOs. So all the PGs should read about the important molecules that have been isolated in HMOs. There are multiple classes again. LNNT, 2FL are some of the important human milk oligosaccharides. Some important contraindications for breastfeeding include a mother who is on chemotherapic agents. This is one absolute contraindication, and an infant with galactosemia. So remember that most of the other conditions, like a mother with HIV, or a mother who is having hepatitis B or hepatitis C, these are all not considered to be contraindications for breastfeeding. In a mother with established HIV infection, where the baby is at risk, we must remember the AFAS criteria to take an informed decision about whether to go for exclusive breastfeeding or exclusive replacement feeding. Both these are acceptable options. So these are not considered to be absolute contraindications for breastfeeding at all. The only absolute contraindication is a mother on potential anti-cancer agents and an infant with galactosemia. We move on now to question 8. So this is the question on preterm nutrition. You have a 15-day-old preterm baby born at 28 weeks gestational age with a birth weight of 920 grams to a primary mother with imminent eclampsia who was on antenatal steroids, who was covered with antenatal steroids. The baby is currently on CPAP and is on orogastric feeds with a volume of 200 ml per kg per day of mother's own milk with human milk fortifier added. So this baby is on completely fortified expressed breast milk at the volume of 200 ml per kg. So you can expect a lot of questions on calculation of calorie, protein, and some important micronutrients in preterm babies. And you may be asked to comment on whether this is adequate or inadequate based on the ESPGHAN recommendations. So here come the questions. What is the recommended calorie protein intake as per ESPGHAN 2022? Sorry about the typo. This is 2022, which is the most recent guideline. The question also asks us about the protein energy ratio. Then we talk about different strategies of fortification like standard and opposed to individualized fortification. Recommended calcium, phosphorus, vitamin D levels and iron intakes, and the growth charts, which provide a prescriptive approach to monitor the growth in the baby. So as per ESPGHAN, there have been a lot of modifications again in ESPGHAN. So earlier it used to say 120 to up to 135 kilocalories per kg per day. Now, most of the guidelines have been recommended in have been revised in 2022 paper. So as of now, the calorie recommendation stands at 115 to 140 kilocalories per kg per day. So when you are adding HMF to expressed breast milk, we reach a calorie content of roughly 81 or 82 kilocalories per 100 ml of fortified mother's milk. So you all know that preterm mother's milk as well as term breast milk have around 67 kilocalories per deciliter or 100 ml of breast milk. And when we add HMF, we are adding 4 sachets of 1 gram each to 25 to 100 ml. That is each 1 sachet to 25 ml. So this will provide an additional intake of around 14 kilocalories. So the net intake comes to 81 kilocalories of calories per 100 ml. So when we are giving 200 ml per kg per day, automatically the calorie intake will be 81 into 2 times, which would be 160 or 162 kilocalories per kg per day, which is little better than what is expected to be provided as per ESPGHAN 2022. The protein intake that is recommended is 3.5 to 4 gram per kilogram per day, but this can be increased up to 4.5 grams per kg per day, especially in extremely low birth weight babies. And protein energy ratio is to be maintained at 2.8 to 3.6 grams per every 100 kilocalories provided. So this is also to be maintained in order to prevent excessive gluconeogenesis from amino acids, and keeping in mind that there is a specific dynamic action for the enterally consumed calories. So there has to be a certain proportionate intake of protein that needs to be provided for uh, every unit of calorie given, and vice versa, in order to maintain an optimal nitrogen balance or anabolism in the system. So standard fortification, which is the universally or most commonly followed strategy, involves the addition of 1 sachet of HMF, which is 1 gram, to 25 ml of expressed breast milk. However, some researchers have tried to say that this may not account for the variations in the human milk protein content, and hence we may end up giving slightly lesser content of protein to preterm, very low birth weight babies. Hence, they have proposed individualized fortification, which has again two strategies: adjustable fortification and targeted fortification. In adjustable fortification, we would adjust the strength of fortification based on BUN levels of the baby, measured ideally twice weekly, blood, urea, nitrogen. Ideally, this must be targeted to be between 10 to 16 milligrams per deciliter. If BUN levels are low, indicating low levels of protein accretion, we should increase the strength of fortification. If BUN levels are more than 16, then we may step down on the strength of fortification, although this may rarely be required. Targeted fortification, on the other hand, includes measuring the levels of calories, macronutrients, and micronutrients using a human milk analyzer or HMA in mother's expressed breast milk, and then trying to add the fortification appropriately in order to reach the targeted recommended dietary allowances based on ESPGHAN. So these are the two other strategies as opposed to standard fortification. We have adjustable and targeted fortification. The other micronutrient intakes which may be important for all of us to remember will be calcium and phosphorus. This usually goes in the ratio of 2:1 in enteral nutrition. Calcium must be provided at 120 to 200 milligrams per kg per day, and phosphorus at roughly half of this at 70 to 115 milligrams per kg per day. Iron, 2 to 3 milligram per kg per day is recommended. And vitamin D, the ESPGHAN 2022, please note, it gives a vitamin D recommendation of 400 to 700 international units per kg per day with a maximum of 1000 international units daily. Now coming to the prescriptive growth chart that is recommended for monitoring growth in preterm VLBW babies, as opposed to earlier charts like Fenton's, which is a descriptive chart which included both the developing, mostly the developed countries, and some other older charts which were intrauterine charts like the Lubchenko's charts. The current recommendations mostly endorse that we use the prescriptive charts, which are growth standards. This concept has come from the intergrowth chart, which was proposed by Willer et al. Based on the assessment of growth standards measured from 3 important domains. So they had a fetal growth domain wherein standard ultrasound-based images were used for calculating the fetal growth. Then there was a preterm postnatal domain wherein those preterm babies delivered within the cohort were followed up with standard nutrition practices and their postnatal growth was tracked. And thirdly, there was a neonatal cross-sectional growth domain, which involved the cross-sectional assessment of anthropometric parameters in term newborns who were delivered to otherwise low-risk mothers. So based on these three components, the uh, the fetal growth longitudinal standards, FGLS, the PPFS, as well as the newborn cross-sectional standards, NCS, the intergrowth chart has been devised. And this chart is now being used for prescriptive assessment of growth. We now move to question 9. So what is the parameter in ultrasound that is being measured here? How do you calculate it? IVH with parenchymal involvement falls under which grade? So basically grading of IVH. Periventricular cystic lesions extending into white matter, what is the grade of PVL? So we'll discuss the grading of PVL and name one condition where resistive index is low. So the parameter that is being measured here is the ventricular index. So this is measured or represented by Levene's index, which is the distance between the falx cerebri and the lateral wall of the lateral ventricle, particularly the anterior wall of the lateral ventricle in the coronal plane at the level of the third ventricle. So we have to be very specific where we are measuring the ventricular index. It is a distance between the midline falx and the lateral wall of the anterior horn of the lateral ventricle, and it should be measured at the level of the third ventricle. So this Levene's index is used for assessing the severity of hydrocephalus. And it is believed that if Levene's index crosses the 97 centile of the norm for that particular gestational age plus 4 millimeters, then it becomes a threshold for intervention in some form. The intervention can be either in the form of repeated lumbar punctures or repeated ventricular taps, wherein every time we may remove 10-15 ml per kg of cerebrospinal fluid, or in cases where this is not settling with these measures, and after ensuring that CSF protein levels have reasonably declined, we may consider a permanent or a temporary diversion based on the situation, such as a ventriculoperitoneal shunt or an external ventricular drain. So IVH, which is extending into the parenchyma, becomes grade 4. So here again comes the role of grading of IVH. There are two different schools of thought. We have wall-based grading, which is based on ultrasound, and papillae grading, which is based on the CT scan. So in papillae grading, which is what we usually use even with ultrasound, we generally tend to use the papillae grading. Grade 1 refers to the presence of germinal matrix hemorrhage. Grade 2 refers to the presence of IVH not causing ventricular dilatation. Grade 3 is IVH causing lateral ventricular dilatation, and grade 4 represents IVH with parenchymal extension. Wall-based scaling or grading uses the measurement of the extent of the bleed occupying the lateral ventricle measured in the parasagittal view or parasagittal plane as a measure of grading of IVH. So in contrast to the papillae grading, the wall-based grading says grade 1 is IVH, which is occupying less than 10% of the volume of the ventricle in the parasagittal plane, 10 to 50% is grade 2, and more than 50% is grade 3. So if there is a parenchymal echogenicity, it is given a separate connotation, and this has to be mentioned separately when we grade IVH. Now, more and more, it is believed that grade 4 IVH is not a direct extension of the bleed, but it is because of venous ischemic changes because of concurrent thrombosis of the terminal vein while it bends and before it drains into the cerebral veins. So because of the unique U-shaped bend of the terminal vein, it is believed that it has high propensity to become thrombosed when there is a large bleed, and this can lead to venous ischemia or venous infarcts, and this is actually confused with a extension or parenchymal bleed. Likewise, there is a De Vries staging or grading system for periventricular leukomalacia, and there are 4 different grades. Now, grade 1, which is the mildest form, refers to the presence of persistent periventricular flare for more than 7 days. And when there is increasing degree, especially when you see cystic changes, we categorize as grade 2. And then if there is more extensive multicystic encephalomalacia, it becomes grade 4 PVL. So when there is extensive involvement, including when it is extending into the white matter, it is generally referred to as grade 4 PVL. One condition where the resistive index is low. So resistive index is a measure to is an index that is used as a measure of the cerebral autoregulation. So it is the peak systolic velocity divided by the difference between peak systolic velocity minus end diastolic velocity. So usually the resistive index goes up in conditions like hydrocephalus, where there is more and more resistance to the cerebral arteries. But resistive index can come low when there is asphyxia and loss of autoregulation. So a decreased resistive index is also taken as one of the important markers of the severity of asphyxia. The next question is on the applicability of pulse oximetry. So what is the principle of pulse oximeters? So the principle is Beer-Lambert's law. The clinical applications of pulse oximeter. There are multiple clinical applications. It is often considered as a fifth vital sign. It is often used for resuscitation of newborns and for the titration of oxygen therapy. It may be used as an apnea monitor for detecting apneas. And it may be used also for neonatal transport, for transporting babies from one side to another. It is also used as a tool for screening for congenital heart defects. Situations in which pulse oximetry is not reliable include low perfusion states such as shock, dyshemoglobinemias, particularly methemoglobinemia, the use of dyes and pigments, optical interference with phototherapy, when the baby has rapid movement artifacts, when there's poor discrimination, especially at the upper end of the saturation. These are all conditions where we may get poor reliability with pulse oximetry. So shock, which is a low perfusion state, dyshemoglobinemias like methemoglobinemia, carboxyhemoglobinemia, presence of dyes and pigments, nail polish, optical interference with phototherapy, movement artifacts, and poor discrimination at upper end of saturation. Usually the target range is 91 to 95%. The alarm limits include 2 to 3% lower and 2 to 3% higher from the alarm limit respectively. And in pulse oximetry screening, which is being propagated more and more for critical congenital heart diseases, a saturation more than 94% in the right hand and a difference between pre-post rectal saturations less than 3% is taken as pass in pulse oximetry screening. Last but one question. What is this machine? What are the three advantages to the other similar screening tool used in neonates? What is the lowest ideal gestational age for its use? And mention the near decibel frequency range used by this device. So this is a Bera machine or a Bera phone. This is a neonatal hearing screening tool, as you all know. The other tool that we often use is a OAE or acoustic emissions. But Bera has some important advantages in the form of being able to identify the retrocochlear pathologies or central auditory pathologies. It can identify severe and profound hearing loss, and it is less affected by external and middle ear conditions like otitis media or serous otitis media, fluid in the middle ear, wax, etc. It also has lower false positive rates and lower rate of referral. The lowest gestational age at which Bera can be done includes 34 weeks of gestational age, and it has a near decibel frequency range of 35 to 40 decibels. So this is the last question of the day. So this is an echocardiographic measure that is used for assessing the significance of PDA. Name this index, what does it measure, and how do you define significance of PDA based on this parameter? So this is a parameter called left atrium by aortic root ratio, LA by AO ratio, which is being measured in the M mode parasternal view in echocardiogram to assess the significance of PDA. It is one of the measures of left heart volume overloading. And a value more than 1.6 is said to be indicative of a HSPDA or a hemodynamically significant PDA. Some other measures of left heart volume overloading include the presence of diastolic flow or turbulence in the diastole when measured in the left pulmonary artery, as you can see in the figure B. So there is presence of diastolic flow in the left pulmonary artery. The presence of elevated left ventricular output, which is measured by this measure called VTI in the aortic root. And of course, the left ventricular volume overloading indices measured by the LV cavity size, left ventricular end diastolic dimension and end systolic dimension, as well as the LA-AO ratio, which we just discussed. So these are all measures of left ventricular volume overloading. Left heart pressure loading can be assessed by the mitral E by A ratio, which is the ratio of the transmitral flow, E representative of passive filling of the ventricle and A representative of filling during the atrial contraction. Normally, E by A in most healthy individuals will be more than 1 because more filling of the ventricle occurs during the passive filling phase. But in healthy preterm infants, because of the poor left ventricular diastolic function or compliance, the E/A ratio will be below 1. So because it is more dependent on the atrial contraction or atrial systole for filling of the ventricle, the E/A ratio will be less than 1. But preterm infants with a large PDA who have elevated left atrial pressure will again have earlier mitral opening and more significant passive filling of the ventricle, resulting in a pseudo-normalization of the E/A ratio, which will again become more than 1 in a preterm baby with a HSPDA. So this is also the reason for the shortening of the isovolumic relaxation time because of the earlier mitral valve opening because of the rapid left atrial filling. So IVRT less than 40 milliseconds is also a measure of HSPDA as a marker of left heart pressure loading. So remember that LAO ratio, left ventricular dimension, increased left ventricular output are all measures of improved left heart volume loading and increased left heart volume loading, whereas mitral transmitral E/A ratio as well as decreased isovolumic relaxation time are markers of left heart pressure loading. So with that, I thank you all for joining us today, and we hope to join you with some more OSCEs in neonatology in the coming weeks. Thank you. If you have any questions, you can please share with them with us either on the Zoom chat or on the YouTube chat. Thank you.